Hello, everyone, and welcome to the MICCAI Fellow Talk Series. I'm Maria Zuluaga, professor at Euracom in Sophia Antipolis, France, and I'm quite honored to get the chance to moderate today to the talk of Professor Marius George Linguraru, who is one of the recent elected MICCAI Fellows, like right in the previous edition of MICCAI. So Professor Linguraru is a distinguished leader in AI and medical imaging research, where he has dedicated his research to improving the lives of vulnerable children and patients with rare diseases. He is the inaugural director of the Division of AI Research and Connor Family Professor and Endowed Chair in Research and Innovation at the Children's National Hospital in Washington, D.C. Professor Linguraru is also a professor of radiology and pediatrics at the George Washington University and a co-founder of PediaMetrix Inc. Thanks to his contribution to the field, he has been recognized with multiple honors, including the Excellence in Engineering Award at the UK Parliament, the Distinguished Service Award of the IEEE EMBS, and of course, he has been recently been elected as the Fellow of the MICCAI Society. And I think I forgot to mention that Marius is currently the president of the MICCAI Society. So Marius, thanks a lot for having accepted our invitation, and the floor is all yours to tell us about all of your exciting research.
Thank you very much, Maria, and hello everyone. Well, good morning from Washington, D.C. And I think after these kind words of introduction, I hope something that stuck there is that AI for children's health in rare diseases is at the heart of my work. And what I will try to convey today is, that there's a lot of excitement in this field and what's to come into how we use technology to increase access to healthcare and to better identifying conditions, personalizing treatment, and improving the quality of life and the overall life of children that suffer very often from rare diseases. So I'm moving on to basically say, just to start with something that I think it's probably quite at the heart of our MICCAI community, and the fact that AI will impact everything in healthcare. And I know there are many conversations about the icebergs that AI produce in healthcare and in society in general. And what I will focus on today is a lot on what's happening under the surface, but I think what's under the surface and what's to come and what's to discover. And it is true that we don't know everything about AI yet, but I think it is very exciting if we use this technology responsibly and with the correct safety guardrails. Because AI, in the end, is a great way of analyzing, sorting, arranging, presenting, and explaining data. And if we do that correctly, I think we can identify actionable items that can really improve the healthcare of our patients of any age. And something when it comes to young patients and children, I'm looking at stories such as this one that appeared a couple of months ago in the Washington Post about the mysterious rise of cancer among young adults, and in this case was in the Corn Belt. This was a story from Iowa in the United States. But what I think this is representative of many things that we're finding new in healthcare, and things that don't really have a pattern that's been recognized clinically yet. But I think with the right type of data and the right type of technology to analyze the data, we'll find better ways to explain the cause of these diseases and to find better treatment for them. And this is where I think artificial intelligence can be a huge leap into increasing better access to healthcare, something I will mention a few times in my talk today, but also identifying solutions to problems that seem mysterious in the clinical world. So I thought I would put my talk out organizing around four themes. First, talking a little bit about the state of AI in healthcare, and then you hear more about what's happening with children, because for AI, just like for clinicians in general, children are not mini adults. So it's really important that we look at children as patients that have very special needs. Then I will tell you a little bit about my favorite MICCAI pediatric projects and some lessons that I learned from these projects, and maybe with perspectives as well. And if we have time, I would really like to emphasize a little bit how we can use technology in a more sustainable and green way. But two things are going to be central to everything I'll present. One of them is responsible AI. And again, the safety, the equity and ethics in the way we use technology and in the way we use it to help vulnerable patients. It's important. And also present a few resources that some of you may find helpful. And I put this morning some green boxes around those resources to make it easier to identify them. But before getting into that, to introduce myself better to you, and both as a MICCAI Fellow and as president of the MICCAI Society, I just wanted to start a little bit with a personal story and with these pictures of two institutions that are really important to me. At the left is the pediatric hospital in Sibiu in Romania, where I grew up. And as a child there, I spent a lot of time in my mom's office, and my mom was a pediatric nurse at this hospital. And she was also my best teacher about learning about healthcare and pediatric healthcare. But I learned a lot about, the hardship of pediatric diseases and what that meant and the impact that had on kids. And I decided quite quickly that I didn't want to be a medical doctor. So to spite my parents, I became a computer scientist, hence my first connection with MICCAI. But many years later, I ended up at the hospital to the right, which is also the house of Dr. Bear. And this is Children's National Hospital in Washington, D.C. And to get between these two parts, so didn't want to be in a pediatric hospital, but I ended up in one. I didn't want to be a clinical doctor, but I ended up being a scientist and a doctor of a different type. That took a lot of training in some of the great institutions that I was fortunate to be part of, and also a lot more mentorship that has started with my mom and then continue with some of the great scientists that are part of the MICCAI Society. And I'm very thankful to them all for the pathway of my career and everything that has meant to me. And I'm hoping that as members of the MICCAI community, many of you also have the facility to and the chance to benefit from what the society and the great scientists we have in it have to offer. So my MICCAI journey has started in 2021, which was the first MICCAI conference I attended. Obviously, my picture was not on the cover of the proceedings of MICCAI, but that was me at the time when I was a student in Oxford. And I participated, and this is one of the great things about being a member of the MICCAI community as well. You can participate directly in organizing the conference, in the many activities that the society is providing. For me, a couple of these really important things have been MICCAI 2024, where I was a program chair, but also with the team we organized this. It was an absolute new opportunity to bring MICCAI for the first time on the African continent. And some of you may have seen from the announcements that we have shown before that in 2028, we're going to go back for but also for the first time in person to Latin America, because MICCAI 2020 happened virtually in Lima. And in 2028, I'm really hopefully going to be in person in Brazil. So we're growing MICCAI, the society, and we're expanding to corners of the world we haven't been so present in before, and it's very exciting. As part of this journey also, I joined the MICCAI board in 2021, and I became president last year. And also, I'm very grateful and honored to have become a MICCAI Fellow. As you can tell, becoming a fellow is not just something that you take home on a paper, but it's also a duty that we have, to the society, hence talks like the ones we have today. And you'll see many talks from extraordinary fellows of the society and from other members of our community throughout the year. This is just one of the many benefits that the MICCAI Society offers. In terms of my work, global health equity, it's also very important to the work that I do. So not just pediatric, but global as well. And one of the first initiatives that I have implemented as a president of MICCAI was the offering the Health Equity Awards, which were announced last year at MICCAI 2025. And we offer 7 awards that have been funded in 2026 in different parts of the world. So that's very exciting. And this is something that I think will continue at MICCAI, at least in the foreseeable future. But also, I'm hoping that we'll have some new big announcements in Strasbourg at MICCAI 2026. I'm hoping you will join us there and you'll learn more about what we'll offer in the future. But the work that I've done and some of these things that I will present to you today has really started at MICCAI. Whether we're looking at genetic screening, at cardiac screening, and neuroimaging, at some of the challenges like BRATS and LISA that we're organizing at MICCAI, this has all started at MICCAI. And therefore, MICCAI has been so central and essential to all the work that I'm doing, no matter what that has grown afterwards. And I'll show you, these are the examples I'll focus more on today, so you learn more a little bit about some of these projects in a moment. But before I get into that, and if you have a chance, please take a snapshot of this QR code. You may have seen an email this morning as well from the MICCAI Society. This is a QR code to the survey that we're launching to learn more from you about what the society can offer to its community and how I'm hoping we're going to fill in all the little gaps on the map you're seeing to the right and extend the benefits and the reach of the MICCAI Society throughout the world. All right, but now moving to medical imaging, because MICCAI does start with MI, which is medical imaging. And this is really at the core of, I think, what all of us are doing. And I wanted to show you, first of all, this image, which is a painting of Jackson Pollock, which is from the National Gallery of Art in Washington, D.C. And science is obviously at the core of MICCAI, where science is what we do best. But I also had, in my life, I had a lot of intersections with what art is. So I was having a little fun preparing this presentation in starting with Pollock. And why? Because this painting has many patterns that seemed incongruous, unrelated, but they are patterns. When Pollock was painting, he was using patterns in his work as well. And that's something that I think is quite important in healthcare, in medical imaging, patterns and how we interpret them. And actually, to quote Sir William Osler, who was a clinician and one of the founding fathers of the Johns Hopkins hospitals, medicine is a science of uncertainty and an art of probability. So this mix between science and art, I think it's at the heart of good clinical practice, and it's an opportunity for AI to be well implemented into this space as well. And why did I pick Pollock as well? Is because my first project in medical imaging, or my first big project when I was doing my doctoral degree, was in breast cancer. And in this bottom image that is showing a portion of a mammogram, I see patterns maybe similar to what we see in Pollock's paintings. Lots of lines, lots of what may be perceived as noise at the first impression, but actually these are anatomical patterns that may be also very indicative for diagnosis. So when I was working in this field, I was really fascinated about, first of all, identifying breast cancer as early as possible, but also about the way the human eye is working. And at the time, I was working with mathematical models that are looking at how the eye fovea adapts to changes in contrast and light. So there are mathematical formulations that actually seem to were quite beneficial for the identification of breast cancer. But this is something that at the time, my fascination was about how radiologists can identify patterns faster and better than others. And, radiologists in the United States trains in higher education for about 15 years. Going to university, to medical school, fellowships and training, you name it, takes a long time. But now with neural networks, we can train a network to identify some of these patterns in a much faster and sometimes quite competitive way. So neural networks and artificial intelligence are clearly important in identifying these patterns, but also for me, I became more and more fascinated about identifying these patterns of disease, not just in a specific disease, but in a child as early as possible. And very often we see a child for the first time at birth. This is what's happening mostly in the world, sometimes prenatally when imaging and expertise is available. And obviously detection as early as possible has huge, huge benefits. So with this, I think in 2026, when you're looking at AI in healthcare, what we see is more and more multimodal and generative AI used in diagnosis. And this relates very much with what I do, what I think many of us do, but also a huge inflection of AI in smarter hospital operations, which is something that I think it's good for us to be aware, because that's where a lot of the investment and a lot of the future of investment is going to happen. For me, it's really important to see AI at the point of care, and that means where the patient is, getting closer to home, getting closer to areas where there are no specialized big clinics, and also looking at screening initiatives, like I mentioned before, screening at newborns, for instance, and global access. Because I think that the biggest leap that AI is going to offer in healthcare, it may be in global access to healthcare, where we'll see areas with limited resources moving much faster on the pathway to catching up with high quality clinical services because of technology, because we don't have enough specialists and time to train them, but with technology and task shifting and using technology for providing better healthcare, things are going to move much, much faster. But there are, of course, big challenges as well. And I will come back to some of these later in my talk about the trust, transparency, and explainability of AI technology. And more you hear about safety, biases, and governance. And if anything, we started maybe looking at this too late and too slowly, but I think right now the healthcare systems all around the world are quite aware that this needs to be addressed as soon as possible. So here is a snapshot of AI-enabled devices across medical disciplines. And to the surprise of some, maybe less of our MICCAI society, we see that actually radiology is the field that has the vast majority of AI-enabled devices, actually about 3/4 of everything that is out there. The next space is in cardiovascular, but there's just about 11%. So it's without doubt one leading field in what MICCAI looks at, and that is radiology. And that can be for many reasons, including, better access to images which are sitting in repositories, digitization, standardization that happens in radiology and not as clearly in other medical fields. And then to look at what's happening in pediatric radiology, again, coming back to what I do, mostly pediatric healthcare. This is a study that just came out and is looking at the number of articles published on pediatric radiology. And as you see, this is a small number. It's about 500 publications that came out, and there are two dominant areas that have published in this space in the US and China. And why I brought this map here is also because it's indicative of what's happening in general to access to healthcare. We see huge gaps on these maps. Because again, coming to 2026, more and far more than half of the world population lacks access to essential care. Healthcare is very expensive, and the United States is one of those examples where last year, 1 in 3 Americans skipped healthcare due to cost. And this, I think, starting lack to access is going to become probably worse in the future, because only in the next few years, there is a prediction that we will be short of 11 million health workers in the world. This is a huge gap. So when you look at these multiple gaps, actually, in access to healthcare, I think it becomes quite obvious that technology and technology using AI has a great opportunity to fill in some of these gaps and bring opportunity for better access to healthcare all around the world. Children then are, again, a specific category within the healthcare groups and quite underrepresented in AI research. Just like you saw on that map from pediatric radiology, I just looked on PubMed, and this may be an imperfect way of counting, but if kids make more than a quarter of the world population, what I found in PubMed, that if I look at AI in healthcare, and then I also put the word pediatric, only about 2.2% of the publications were specific for kids. So this is a huge gap for many reasons, including the fact that, we have less data from kids, we have vulnerable populations, have high level of protections and of access, but also lack of investment into conditions that impact kids. And this is critical because what this image to the right is showing is that kids die from different diseases than adults, or there are diseases that kill only children. As we get older, we get more cardiovascular problems, we get cancer, we get neurological conditions. These are not necessarily the big problems in pediatric healthcare. And neonates are still dying very often from diarrhea, these are addressable conditions sometimes that I think impact too many kids and take too many lives. So again, if we have to train pediatricians to look at diseases specific to kids, AI algorithms have to learn that as well. But also these diseases that impact kids, when children suffer from severe diseases, those diseases are typically rare. Now, the definition of a rare disease, for instance, in the United States, is that it impacts less than 200,000 patients at a population of about 350 million. But if you look globally, rare diseases are common and impact more than 300 million people. And particularly kids, 1 in 3 kids will not see their 5th birthday if they are born with a rare disease. And many of these have genetic conditions. So remember some of these facts as we go through some of the projects later on. But the bottom line of this introduction is that children are not mini adults. Diseases that impact children may not be the same that impact adults. Diseases that kill children are different than those that kill adults. And pediatric specialists are trained to take care of kids, and we have to train AI algorithms in a different way also to benefit children impacted by some of these rare diseases. And with that, then in the next section of my talk, I'd like to go to some of my MICCAI projects. This is just a snapshot of what we're doing at Children's National Hospital with the lab here, the Pediatric Accelerated Intelligence Lab, and with large networks of collaborators that I will acknowledge at the end. And what I chose here are 4 areas. First, how we measure brain tumors with far better precision. To look at brain tumors, we need neuroimaging. So advanced neuroimaging is also important. And then how to screen for some rare and ignored conditions that kill many children around the world, and how we can use technology in smart and responsible ways to do that. But for all of these examples, something central to them is responsible healthcare. And here I got a snapshot from what the World Health Organization calls a responsible use of AI. And you'll see here things that I'm hoping everybody's familiar with. And if not, I think they will resonate with you. That protecting the autonomy, promoting human well-being, just like doctors have to do as well. Transparency, explainability, intelligibility, important in algorithms. Being responsible and accountable in the use of technology, just like we are in clinical use as well. Inclusive and equitable. And here's something that I'll come back also to the end, promoting AI that is responsive and sustainable. Thinking about how we use resources is also important for our health. But here is quiz number 1, and this being virtual, I'm going to provide you the answer as well. But rare diseases impact everyone and impact people that we know. So here is Elizabeth Taylor, John McCain, and Michael Bolton. They all suffer from brain tumors. So brain tumors, again, I'm going to speak about pediatric brain tumors, but we know people around us, or we know of people that are impacted by them. And this is something that is happening with all rare diseases. So measuring these brain tumors is important because in pediatric care, cancer is the leading cause of disease-related death. And so kids, 44% of the disease-related deaths in kids are caused by cancer, right? This is different than what you have cardiac conditions in adult ages. And among these cancers, the most prominent is brain cancer. And there are other categories of brain tumors. And actually, I chose one here that I find the hardest to measure. Because when we think of tumors, very often we think of a blob or something round that you can measure with diameters as it's happening in clinical cancer, but this is not always the case. This is a case here that I'm showing of optic pathway glioma. So this is a tumor that can grow on the optic nerve, right? It's coming out of the eye, as you see in this image here, and then it goes into the chiasm and in the tracts. Actually, this is the anterior visual pathway. Here to the right, AI segmented with the nerves, chiasm, and tracts. And this is how it looks healthy, in a healthy way. When tumors appear, they can change the shape and the location of at any location of the anterior visual pathway. So when you have a condition such as neurofibromatosis type 1, which is the most common precancerous condition, genetic precancerous condition, where tumors can grow anywhere on the nervous system in the body. So you can have them on your optic nerves included or anywhere else. Those are hard, first of all, to predict, and secondly, to measure. And why? Because as you can see here, when a tumor grows on the anterior visual pathway, we don't have the typical blob round, easy to measure. So here is a child that at diagnosis, time of diagnosis had no issues. At a follow-up is found out with a quite prominent tumor on the chiasm, then goes on chemotherapy, returns 1 year later, and the clinical team celebrates the response because the tumor in the chiasm that I'm showing here has decreased. However, something that the clinical team could not measure well is how the tumor has moved on the optic nerve and how the size of this tumor has changed. So while to a clinician this looked like a decrease in the size of the tumor, in fact, the growth of the tumor was more than 20% in volume. So this was quite the opposite of a positive response. So of course we can do this, we can segment this well with AI and image analysis tools, but we can also show the patterns of change. So this is really important. So we became more and more involved with pediatric brain tumors. And I'm hoping that many of you know of the BRATS challenge, the brain tumor segmentation challenge that had started more than a decade ago, but only for the last 3 years, we had a pediatric portion here as well. So in 2023, we attended there, then we were back in 24, and we expanded to data coming from sub-Saharan Africa, again, areas underrepresented in data. Here is at the bottom, the picture in 25, and you can see my team here. You have Saeed Anwar and Harim Nissar and Daniel Capeyan, who's from Madrid, and Abhijit Parida, Austin Tapp, Zifan Jiang. We got some of the top performances, first of all in pediatrics, but then moving into other areas as well. And I told you that I'll show about some resources through my talk as well. Here is, if you go to the link I'm showing here, you'll get the data that comes from the pediatric BRAT section, which I'm co-organizing with Anahita Fatika Zeruni from Children's Hospital of Philadelphia. And we put on Cancer Imaging Archive recently more than 400 cases with fine annotations of rare pediatric cancers. Actually, just yesterday, the paper I'm showing here to the right came out on Radiology AI, so you can access it now online. It's free access. So what have we learned through this process as well? That we started focusing on pediatric cases, and then we move more and more to other types of tumors, brain tumors that impact mostly adults. So what we presented last year at BRATS was a pipeline that now, from learning what works well in one type of tumor, we expanded with adaptive processing to other types of tumors, and that actually works very well. And maybe without surprise, this is an ensemble of neural networks and of different models, and then we're using a ranking system with model weighting for this ensemble. But this adaptive processing basically shows you that you understand well the differences between what's a pediatric tumor, what's an adult tumor, what's a metastasis, what's a meningioma, what's a high-grade glioma. And this is something that I think it's also indicative of what's happening in other areas of medical imaging, where we now have tools that actually work quite well for a baseline, but then we have to understand very well what's happening in the biology, the anatomy, the presentation of the condition to adapt it to work well there. So the resources, again, that we provide here are, first of all, web apps. If you go, you can either scan the QR code here or go to the website I'm showing to the left. And here we have multiple models for pediatric brain tumor analysis, high-grade glioma, optic pathway gliomas, and other tools that are free to use. And you'll get your result in a few minutes online, and you can download the results and use them however it's appropriate for you. We get, in the last month, we just got some stats here. We had more than 1,500 visitors from 22 countries who have used this web app. So we're very happy to see that this is a resource to the community. And also, again, with Anahita Fatika Zeruni and the team of Rapno AI, we have published at the end of last year 2 papers in the Lancet Oncology that talk about what role AI has and what are the perspectives for pediatric neuro-oncology with AI. So this is a field that, again, is moving well and where quantification and automation are playing an important role. And of course, BRATS 2026 is back, and there are a family of challenges happening on the BRATS. You can find the details online at this website or to the MICCAI website. So if you are to look at tumors, brain tumors, we need MRI. And MRI is maybe one of the most expensive, harder to use medical imaging modalities. As we say in a hospital, you build a hospital around an MRI machine because of the many special needs these machines have. So look at this statistic here, and this is changing, by the way, almost every year. This shows the number of MRI units per million inhabitants, where it shows that Japan is leading in the world, followed by Greece, South Korea, US, Germany. But if you go down the list on this, you'll see that these are all countries of high income, maybe middle high income. And that's, again, an indication of expenses and resources. So it's hard to have MRI machines, and there are countries in the world that have 0 MRI machines on their territory. And here, something that I find very exciting and I've been working with for a few years is this portable MRI machine. This is made by Hyperfine. It's called SWOOP, or we call it at our hospital R2D2 for probably obvious reasons. This is a portable, very important, lower cost, also important, low energy machine. It plugs in the wall. It's way lighter, about 10 times lighter than a typical MRI machine. And instead of what we used in our research or high resource clinical care of machines of 3 Tesla magnetic field, this one has 64 mini Tesla. So it's about 50 times lower in magnetic field intensity. And that's great because you can bring it in the operating room. You can put patients that are hooked on machines into this machine and look at their brain, but it comes at a cost as well, and that's image quality. So what we presented again at MICCAI for the first time, and next week we're going with my team to ISMRM in Cape Town in South Africa, where we have a number of presentations on this field as well. First of all, we're showing how we're improving the image quality from what you see here to the left, a typical T2 MRI acquired with R2D2. And what you see to the right is how we enhance this image with AI. And this is not just super resolution, it's increasing the contrast, the anatomical definition. And this is also an image of a toddler. So in young brains, myelination is low, so you don't see the same contrast and definition sometimes, right? So that's important as well to keep in mind, and why tools designed for adult MRI don't work for kids well. And this is, you see here to the right, how we're using actually a shared encoder, because from a T2 that can be acquired in 2 minutes with this machine, we create not just a high quality T2, but also a paired T1 without even having to acquire a T1. And this is the work, Austin Tapp and Kritika Iyer are leading in our lab. Also, we then, and our collaborators from Children's Hospital Los Angeles and the team of Natasha Lepore and Sean Dioni from the Gates Foundation, who is leading the Unity Consortium at the foundation, we're developing tools to analyze what's inside these MRIs. First, with better quality of images, we get better quantification. Here I'm showing you just how we look at the major brain structures, but we also look at subcortical structures and so on. And why is this important? Because we have collaborators in many countries. Right now, we have thousands of scans from kids, many of them in sub-Saharan Africa or South Asia. We're looking at patterns of brain development in different regions of the world. And this we could not have done without this portable MRI and the tools to quantify that information. And we're seeing impact from, maternal anemia or HIV, you can look at that, malnutrition. Some of these things are actionable if they are identified early, the risks are identified early, and the risk for a child not to thrive. And what I'm showing here also to the right is how we can look at volumes inside the brain, smaller volumes, bigger volumes, but also sociodemographic factors. For some of these kids, you have readings of EEG as well, and how these combinations can predict how in the future a child will thrive or not in motor skills, language skills, in neurocognition. And again, this will be, those of you who will be at ISMRM will have a series of presentations next week or maybe in 2 weeks in Cape Town. So these tools are also important because beside imaging, gaps in imaging, we also have gaps in imaging capacity. And what I'm showing here is from a story in the Atlantic, just very briefly, that in the US, in one city in Boston, and more than that, in one neighborhood, Longwood, which is where the hospitals of the Harvard Medical School are based, we have as many radiologists as you have in this entire area in West Africa. So imaging, important, getting imaging, but also interpreting imaging is equally important. A resource related to this is the LISA Challenge that also continues in 2026. And here you have access to some free imaging, and you can participate in the task of the challenge looking at image quality and segmentations. If this is something you're interested, please look up the MICCAI website or the address here. And here I wanted to show you a picture from a trip last year in Malawi, where I was traveling, and it was during a cyclone. It was pouring. The hospital was in dismay because of the weather conditions. But here was R2D2 working and looking at a child with cerebral malaria, because this is one of those areas where we don't quite understand what's happening in these severe expressions of malaria. This child was comatose, and we were able to look at his brain and do a scanning. But also the child was undergoing a clinical trial done by my colleagues at Children's National. And to everyone's great joy, the child woke up the next day from the coma. And these are some of these unique opportunities when you get to see what's happening in the brain also, and to match that with great clinical care done at the point of care for the child. So again, these are great opportunities, I think, to look at some of these sometimes ignored diseases. Another thing I want to show you briefly is about how we do screening for genetic disorders. And here I would have another question, maybe three, in this case, gentlemen, statesmen, quite famous. First, Julius Caesar, then Abraham Lincoln, and ending up with Charles de Gaulle. And all of them had, or we think they had, one rare disease. So a rare condition, but also actually quite the same. This is Marfan syndrome. One of the rare conditions, rare diseases, one of those 7,000 to 8,000 conditions that are out there in the world that can impact small categories of people. So again, rare diseases impact everyone. So more than 8 million newborns have birth defects every year. And as I showed earlier, right, a child born with the rare disease, 1 in 3 kids born with the rare disease will survive less than 5 years. And many of these have a genetic condition. So genetic capacity is another one of these areas where we have few people. In fact, if you look at this map, which is a few years old, it's like 3/4 of the genetic counselors in the world are based in the Americas. Asia, the most populous continent in the world, has probably the biggest gap in this kind of capacity. And why is this important? Even if you think of a condition that is not even rare any longer, like Down syndrome. In the United States, a child born with Down syndrome in the 1960s would survive on median 1 to 2 years. Now we see individuals with Down syndrome living into their 60s because of early detection, of education, and preventive care. And here, what we're doing, we started to work with facial analysis because genetic conditions often have facial dysmorphia. And we were part of a story in The Economist a few years ago, where this was kind of, one of the miracles that was happening in science. And there are many stories about how what machines can tell from your face in the society. But things have changed so much in the last few years, and this is part of the excitement of artificial intelligence and sometimes, the pacing in which we see progress in that field. So we created an app that we called MGene to collect and then to allow us to analyze faces for dysmorphia. And this is a publication that was led by Antonio Porras in the Lancet Digital Health. Antonio is now with the University of Chicago. And we looked here at data from about 3,000 kids from all around the world to see if we can identify patterns on the face and how early that may be an indication of a genetic condition. I don't know if you hear the sound here or not, but this is to show you how we can use this app very easily and in all kinds of conditions. Like in Yemen, this is Sarah Barazir, she was a fellow with us. She's now based in Abu Dhabi. She traveled to a refugee camp in Yemen. This was a few years back, where she was collecting data, because this is the beauty of simple to use technology that is portable. She was in Liberia as well. She traveled in a number of countries, and this is how we got access from thousands of kids, and we're looking more and more at newborns from different parts of the world. Well, I'll stop the video here because of timing, but I wanted to show you how we're doing right now. We have a project in the Democratic Republic of the Congo, where basically there are no clinical geneticists and counselors available. But here is, this is my most recent trip there. Kizito, who's next to me, he's a pediatrician that we trained in kind of clinical genetics as well. And he is the voice there. We're looking at Down syndrome again to identify kids early and to see, can we make a difference there as well, as we've seen this happening in the US and it's happening in other parts of the world. But we're also looking at sickle cell disease, because this is a very prevalent condition that we're seeing changes in facial dysmorphia with the progression of the disease. And the last example I wanted to show you here is how we look at cardiac conditions. So again, very, very severe conditions that can be life-threatening. And cardiac conditions impact many people, but here I'm looking at a specific cardiac condition, and that impacted, we think, Michelangelo Antonioni, right, hundreds of years ago, Auguste Renoir more recently, and also Frida Kahlo, who actually made a painting that you see here in which she exposes her heart. And this condition that I don't know how many of you are aware how impactful it is rheumatic heart disease. So rheumatic heart disease is a complication from strep throat. And I could almost bet that everyone online here had strep throat at some point. But you get antibiotics and it's fixed easily. This is a silent condition that you don't hear at the stethoscope until it becomes severe and requires surgery. The condition impacts more than 50 million people around the world. And there are about 400,000 annual deaths that are accounted for. And if you don't hear it by stethoscope, you want to hear it by, you want to identify it by ultrasound. And ultrasound now, I'll go back to Jackson Pollock, right? Looks a lot like a painting by Pollock. It's hard to interpret. So what we created here is this technology called radar. And you see to the right, a portable low-cost ultrasound machine. You can train someone in a few days how to use this to acquire images of the heart. And to the left, it's a laptop. And here we work with a company in Singapore called Us2AI. They took our algorithms, put them on the platform. Because this picture is taken in Kampala, in Uganda, we don't often have Wi-Fi working there. Sometimes electricity can be down as well. So you charge your laptop, use Bluetooth for transmitting the data to the laptop. And again, this is just a laptop. In less than 1 minute, you get a diagnosis of rheumatic heart disease. This is work that is done by Pune Roshani Tabrizi, again presented for the first time at MICCAI. And she's looking at video analysis with temporal attention and spatial temporal attention as well. It's again a complex network that you use there. But what I wanted to show you here is that packaging a complex technology like that into a small device like this laptop is really critical. And this is why we are on the front page of the Washington Post for this, because this is what brings the technology to be used at the point of care where these kids are. Again, I hope the sound comes through. This is Kelsey, our former fellow, who's now at Vanderbilt, and Joseph is a screener in Uganda. And what I wanted to show you how the device works in Uganda, because what we're doing now, and this is in Uganda, we're starting with a program funded by the American Heart Association, and this has been funded also by Coefficient Giving. Obviously, funding is very important for all of these projects. So this new program is going to look now in Uganda at more than 16,000 kids with and without AI in a randomized trial. And once we have the results of that, we're going to move next to Timor-Leste and Brazil. And we're going to do a more global expansion of how to use this technology that has a lot of life-saving potential. So let me tell you about some of the lessons learned. First of all, going back to Jackson Pollock, right? We have rare data, so synthetic data is important. And here, if you go to the GitHub address down here, I wanted to show you again the videos, because here to the left, we have a real case with rheumatic heart disease. To the right, we have a synthetic case created by Pune, also rheumatic heart disease. You can find some of these images online, but also some of the code on how to create this, because creating dynamic ultrasound with disease as well, it's not easy. Then harmonization of data is important as well. If you go back to this QR code, you can find the tool to harmonize MRI images. We're doing the same thing with histopathology now. And you have a publication down here as well. This is with Abhijit Parida and Holger Roth from NVIDIA, who's our close collaborator. And we're doing this also now in a space of federated data, because it's one way to harmonize central data, is another way to do it in a federated way. You can find more resources at the links I provide. Privacy, again, with federated data is really important. And here I want you to show you a study that was published in 21 in Nature Medicine. And this was led by Itai Dayan, who is now with Rhino Health, actually a company that came out of this study and a leader in federated learning, and was also done a study with Harvard and NVIDIA. We look at data for more than 16,000 patients from many institutions around the world. But I wanted to show you here is that this was a COVID study. The only site that had pediatric data was Children's National. So again, children were underrepresented in this group as well. Nevertheless, data for kids benefited from it. So if you don't have enough data from kids in some of these studies, what do? You learn from adults when possible. And this is a study published at the end of last year in Nature Communications, led by Daniel Capean Martin from Politecnica Madrid, looking at pediatric tuberculosis. Because pediatric tuberculosis appears differently than adult tuberculosis, but you still have to learn some patterns. So part of this with Sai Danwar from our team, they created a foundation model of chest X-rays that has more than 1.2 million cases. So learning from adults to kids and transfer learning when it's possible, it's a great benefit. Then I also wanted to highlight this resource, which is a paper led by Karim Lekadir from Barcelona about future AI. I'm hoping everybody has read it. If not, please do, because it's important to think how to be fair, universal, traceable, usable, robust, and explainable in AI, and how to keep that in mind from the very, very beginning of your project. So, kind of wrapping up, integration of AI in healthcare still remains a challenge. Although 2 in 3 physicians use AI in the practice, more than half of Americans, and I think this is reflecting what's happening around the world, are uncomfortable with health AI. In fact, the only strata of the population that is just on the verge of being comfortable with AI being used in their healthcare are those who know a lot about AI. Other than that, regardless of background, income, and social demographics, nobody's comfortable with it. And I think that has to do a lot with the education about AI and with the right communication about implementing AI. And here is a paper that we published, I think in 24, with MICCAI and RSNA, the Radiological Society of North America, experts about the clinical, cultural, computational, and regulatory considerations to deploy AI in radiology. And I think it's, again, important to think about that early and to do it adequately and with trust. Because future AI will augment human expertise, and that's an important message to have right now, regardless of where that goes. And I'll go over this briefly, but I think a human-machine collaboration is an important message we have to have about healthcare at this time. While we're still working about trust, both for clinicians to trust data science and AI, but also scientists, AI scientists to trust how they work with clinicians. Because distrust in AI is everywhere, as we see in big media. And these are just some very recent stories in Washington Post, New York Times, Reuters, about how AI does not work well in healthcare. And those cases exist. But what's also happening is the fact that distrust in technology impacts policy. I often get questions about loss of skills and confidence. That will definitely happen, but we have to be prepared for it. And instead of opposing it, we have to think how we address it and address it early. Because AI adoption will be uneven, that's one thing. And when it comes to healthcare, we all have, our AI on these little devices here on our phones, and we'll have soon 8 billion doctors who self-diagnose themselves before they go to the hospital. And that's a different type of conundrum in the way we have to look at healthcare in the future. I also think that the first AI malpractice is probably just around the corner, and we'll hear about that soon. Societal implications are big. Here is a picture about the state of Virginia, right at the border of Washington, D.C., where now there are more than 600 data centers. And these are popping up like mushrooms. And this is something unprecedented because AI uses a lot of power and energy. And look at this graph by McKinsey that is showing us how much more energy we're going to spend with AI. And it's got its issues as well. So what I wanted to show you here at the end is this paper led by Harim Nisar and Austin Tapp looking at green AI recommendations for AI. And there's a set of recommendations, and you may look at this and think, yeah, this is quite obvious. This is important to do, and we're all thinking about it maybe in the back of our mind, but how do we do this? So what we find in those paper, it's actually some green AI recommendations with really what to do and how much energy you can get, for instance, from adding power caps to GPUs, right? How much efficiency you can get through that. Or using float 16 instead of float 64. It's about saving a quarter of the energy consumption. But also that paper will tell you how to do at what stage of the AI training or deployment you get the best benefits from it. And we'll also recommend some tools that have been developed by others and how to implement them in your work. Also with Austin and with Holger Roth, we're looking at how to do federated green AI because different environments have high efficiency clients to low efficiency clients, and that impacts a lot the use of energy. Like you see here depending on what type of GPU you use, you get different consumptions. And also the tier of emission, which can be geographical and by continent. So this is a different paper. And also you see here the link to the archive if this is something that you're interested in looking at. Because in a world of huge digital divide, where a hospital like mine or some of your institutions have these huge computing clusters, a pediatric hospital like the one shown here in Kampala has very different resources. So having low resource tools and infrastructure, I showed you apps, I showed you some portable devices and how to use this is important. And Abhijit Parida is working actually on a feather depth, something that I think we'll have soon ready to share with the community. But sustainable and green AI, which is one of the pockets here, is also important, but in being responsible AI, because I think if we are responsible, AI will prolong life by saving them with early detection, improving treatment with faster drug discovery, preventing and managing complex diseases. We can do that with our smartwatches now. Saving lives with care is scarce because global health, and I think low resource area will benefit probably faster and better from some of this technology. And in the end, I think AI will not just prolong life, but also help our patients live better through their life. And now moving away from AI with a quote to end, this comes from a very human brain, and that's Stephen Hawking, who said, "Our future is a race between the growing power of technology and the wisdom with which you use it." And I think kids of today and next generations, if they'll be responsible and careful and sustainable with AI, they will get great benefits, not only in the healthcare, but also society. And this is a video done by Thidia Poli, our student. Thank you to my team from the Pediatric Accelerated Intelligence Lab, and I'm very proud for the work they're doing. And again, I showed you just a snapshot of the many things we are doing here. To the many collaborators, supporters, and funders of this work and everything that we do, because without them, this would not be possible. And just remember, MICCAI 2026 has changed location. So we'll be in 26 in Strasbourg in France. We also changed dates. You'll find everything on the MICCAI website. We're going back in 29 in Abu Dhabi, but in 26 we have the same team, just a different location. And I invite you again to engage with the MICCAI Society through our media channels, but also with this QR code and a survey where I hope we're going to hear a lot about how we can help you and how you support you. And with that, I will stop here and thank you all for your attention.
Thank you so much, Marius, for the very interesting talk. I enjoyed also you sharing your pathway from all your journey from the very beginning and how your parents' job inspired you. I felt personally touched by that because my parents are also doctors, so we have some common pathways. We have some questions in the chat. So, and again, for everyone, again, thanks for joining. And if you have questions, please post them in the Q&A box that I'll read them here. So our first question is from Shudong Ma. So he says, "Hi, Professor Linguraru. Thank you for the wonderful talk." Shudong is a postdoc working with Professor Bartek Papi at Oxford. And his question is the following: AI research in healthcare is progressing quickly, but clinical adoption still faces challenges like hallucination, which raises safety concern and complicates regulatory approval, such as FDA, for instance, under current frameworks. And he would like to hear your thoughts on how to address hallucination in clinical AI and how regulatory pathways might evolve while ensuring patient safety.
Right, and this is a great and complex question, and I'll just say something very briefly because I know we're a little bit out of time. But I think first of all, when you think about technology, you don't always have to use the broadest, most free to work technology when you can control some of the hallucinations. Like hallucinations are big in LLMs and generative AI, where I think doing domain specific and controlled GPTs, let's call it GPTs, becomes more and more important in healthcare. You tell you train your technology on domain-specific data, right? So you make them more niche, more focused, and with fewer hallucinations. And I think that's also part of the governance that needs to happen in the hospitals. And that's also a complex thing where you have to look at how does this impact the implementation and the transparency of what's coming out of any algorithm. And that's something that I'm happy also to talk offline about, because governance is not something that is globally and equally available to everyone to do. A big hospital can do good governance. A small pediatric adult humanity practice will not be able to do that. So how do you ensure that small practices, and again, limited resource practices, would also benefit from that? That's something where I think there's a lot of space to grow in terms of sharing information and governance in specific.
Thank you. I'll move to a question from Costas, Marius, which I think is closely related to what you were saying at the end. So it says, Dear Marius, in low data settings like pediatric oncology or the small practices that you mentioned, where tumors are biologically distinct from adult cancers, do you see more promising foundation models with transfer learning or in methods designed specifically for small domain-specific data sets?
Yeah, again, a great question. And actually, my answer there is possibly both, because that depends on the type of tumor and the manifestation of the tumor. So when you have something, I was showing some examples, for instance, with gliomas. Some of the brain gliomas, they're not the same necessarily. They don't have necessarily the same genetic code, right? But some of their appearance can be similar. So in instances like that, can you do some transfer learning? Possibly. But they are also very distinct and biologically distinct tumors like that, where I think specific models will work much better. So again, I don't think it's an answer that fits it all. It's very domain specific, and this is something that's the way I look at all applications. Actually, what is the clinical application? What do specialists do? It's a conversation that goes on for a good while before you can land on what's the best technological development that would benefit that.
Thanks again. So there's a question, and I'll just rephrase because I think it's really close again. So someone is asking for two specific applications: enhancement of T2 or generation of T1 have risk of hallucination. So they're asking how you handle the risk. So do you say it's always going to be application specific, or you think something can be thought of?
Yeah. So what I was showing earlier as an example there, one thing in that application where these kids were healthy, right? So important to think that when you create, for instance, a T1 out of a T2, and you assume this is healthy tissue, then it's something where my expectations are much more, and this is going to work well, very likely. Once you have pathology, I think things become a little bit more complex. So we're presenting also next week at ISMRM an application where we had kids from the University of Bonn with our collaborators there in the NICU, and we look at kids. So these are newborn, preterm babies sometimes. So again, very complex brains and actually developing brains. So that makes everything very, very hard to look at. We had neuroradiologists looking at data. These all are pathologic, yeah, with only R2D2, as I call the hyperfine machine. And they were less than 50% accurate on diagnosis on the ultra-low field MRI. On 3T, standard of care images, they were 95% accurate, as you would expect. On ultra-low field enhanced with AI, they went from, it was about 48% to 92% accuracy. So actually what that was showing, that was for diagnosis, right? The layer of hallucination maybe was actually quite low, if you can think about it. So what the technology could produce well was diagnostic quality images, even if I would agree, I think if you want to go to the biological or subvoxel level, I would not necessarily say every voxel is correct, but it is good enough for giving diagnosis and doing a follow-up from there.
Thank you. And we have Amit Gupta. where he first of all thanks you for the insightful talk. So Amit is a pediatric radiologist and researcher from New Delhi in India, and he's interested to know your view on where is AI likely to have greatest near-term impact in pediatric radiology? Would it be image interpretation task or non-interpretable workflows tasks such as protocoling, reporting, triage, communication, and quality improvement? And what would we as a community prioritize now to make these tools clinically useful and safe for children?
Yeah, that's also a great question, and I think there are multiple ways to think about it, and depends very much of how a hospital would use and implement that. Because I think first of all, it's again a matter of implementing this with safety and accountability. And radiologists and pediatric radiologists the same way are risk averse, right? So first of all, making sure that this is not interrupting a workflow, but rather enhancing a workflow is really important, and is doing it safely. I'm looking at this time, I'm working with some of my colleagues at the implementation of some of the brain tumor tools in the clinic. And actually, these are really great conversations to have about what are the steps of implementing that and doing it well. Because one of the things is the AI has errors, right? And what's acceptable in terms of errors? How does it compare with the clinical practice? And how do we make that put it in such a way that it is interpretable and it's moving forward? So I think one of the questions there is this something that we do on non-interpretable data or more established? I think the first step is to do something more established where it works well. When it comes to reporting and all of that, that's a very straightforward way of implementing some of the technology. I see that much more of a thread on hospital operations, right, and improving operations, where you can do the reporting, you can do better reporting, cleaner and nicer already, without having to implement necessarily more complex algorithm into the clinic. But hopefully you also get automatic reporting of some of the volumes, radiomics, right? And what do they mean in terms of predictive analytics, which is what I think one of the great opportunities to use AI in the clinic, and where hospitals and clinical centers are most risk averse, right? In predicting for the future. So again, this is a long conversation that I would love to talk more and about some specific things as well. But yeah.
Okay, we have just one last question. I think we have the time there. So Mohammed Al-Masni, thanks you for the excellent talk and impressive work. And he's very interested on meta-learning. Indeed, he will be at ISMRM 2026, and he hopes to have the chance to discuss this with you. And so he wants, to know, what do you think if meta-learning approaches could help improve the segmentation of pediatric brain tumors, since you say that pediatric cases are not just simply mini adults?
Yeah, I think so as well, and I think this relates a little bit also to what I said earlier. It's a case by case situation, right? And weighing the advantages and possibly the risks for that. But that also seems like an opportunity to have a conversation in Cape Town soon. So yes, Mohammed, let's get together there and talk some more and exchange some ideas.
Fantastic. You have now an appointment. So I'll conclude with Kanika Bala, that thanks you very much for the wonderful talk. I join him on this. He says your work is truly inspiring. So thanks again, Marius, for sharing your fantastic work and for leading the MICCAI Society. Thanks everyone for attending this MICCAI Fellow talk. I'm copy pasting in the Q&A, I believe, and I hope, the link to the recording in case you want to watch it again or share it with the colleagues that could not join. And that's it for today. Thanks again, Marius, for having accepted our invitation.
Thank you very much. And I look forward to see everyone in Strasbourg in September at MICCAI 2026.
Yes, please book your tickets to Strasbourg, not to Abu Dhabi. Yes. Thanks everyone again, and yeah, see you in a future MICCAI Fellows talk. Bye bye.
Bye bye.